First, we'll be assessing the patient's mental status. This is easily done by first checking for the patient's level of alertness, just by your conversation with the patient, and or if it's post-procedure, just how quickly the patient wakes up post-anesthesia. Other ways to assess for the patient's mental status include orientation questions, and some common ones include the patient's full name, current location, date of birth, today's date, and I also like to throw in a current event, such as the current President of the United States. In addition, you may want to test the patient's ability to recall 3 items, and this is usually done right here at the beginning of the neurological exam. You ask the patient to recall 3 items. I like to choose apple, table, and penny. You conduct your neurological exam and you have the patient recite these 3 back to you about 3 to 5 minutes later. Now, what is being tested under the mental status exam is the following. For example, a decreased level of consciousness will indicate that there's lesions in the brainstem reticular formation, or bilateral thalamic or bilateral severe cortical lesions. Next, we'll be assessing the patient's cranial nerves. Now, commonly tested cranial nerves are cranial nerves 2 through 12. Note that olfaction is typically not tested unless you're concerned about a frontal lobe tumor or a lesion. You're going to start with the ophthalmoscope exam as well as vision and visual fields, both innervated through cranial nerve 2, the optic nerve. When you're assessing for the patient's vision and visual fields, a monocular vision loss will indicate a lesion prior to the optic chiasm. Visual defects in both eyes, such as a bilateral hemianopia, will indicate lesions behind the optic chiasm, such as the thalamus or the optic radiations leading to the primary visual cortex, or perhaps an occipital lobe pathology itself may be secondary to a stroke. As you see here in the video, assessing the patient's visual exam, I'm testing here the visual fields, and what you do is make sure you cover up each eye individually and test all 4 quadrants of the patient's visual field. A good way to test for this is to have the patient tell out how many numbers they see in each field. As you're testing each side, it's important to change the numbers on each side, and this way you can accurately assess whether the patient has a visual field cut or not. Next, you'll also be assessing for the patient's pupillary light reflex. Here you'll see the light reflex is mediated between cranial nerves 2 and 3. Cranial nerve 2 is the optic nerve, which mediates the afferent limb of the pupillary light reflex, while cranial nerve 3, the ocular motor nerve, is responsible for pupillary constriction. A swinging flashlight test might be useful if you're concerned about a patient having what's called an afferent pupillary defect, which localizes the lesion before the optic chiasm. An afferent pupillary defect is typically seen in cases of optic neuritis. What you would do with the swinging flashlight test is you'd shine a flashlight in the good eye and note the consensual response to light in both eyes. Both eyes should constrict. You'll quickly swing the flashlight over to the affected eye and note the dilatation of that eye or the lack of pupillary constriction. This is considered a positive test. The next component of the cranial nerve exam is going to be assessing for extraocular movement problems. Now, the extraocular movements are innervated by cranial nerves 3, 4, and 6, which are the ocular motor nerves, the trochlear nerve, and the abducens nerve, respectively. Now, almost all muscles that innervate the eye movements are innervated by cranial nerves 3, the ocular motor nerve. There are some exceptions to this rule. The superior oblique muscle is innervated by cranial nerve 4, the trochlear nerve, and the lateral rectus muscle is innervated by cranial nerve 6, the abducens nerve. You will also be assessing the patient's facial sensation and muscles of mastication done through cranial nerve 5, the trigeminal nerve. Have the patient clench their jaw and note for any abnormalities as you're palpating it. Additionally, you can perform the jaw jerk test, which is done when the patient's jaw is open. You're going to place your fingers over the chin and gently tap. Note any upward movement of the mandible, as this would indicate an upper motor neuron lesion. Additionally, you're also going to be testing for the patient's facial expression, and this is mediated through cranial nerve 7, the facial nerve. You would do this by having the patient smile, puff out their cheeks, raise their eyebrows, and close very tightly. Note for any asymmetries, and you may also note for any subtle signs of facial weakness, such as a flattened nasolabial fold. You will also be testing for the patient's ability to hear with cranial nerve 8, the vestibulocochlear nerve. This can be done through just kind of rubbing your fingers together in each ear. Make sure that the stimulus is equal on both sides. You can be assessing for the patient's palate elevation through cranial nerves 9 and 10. That's the glossopharyngeal nerve and the vagus nerve. Simply have the patient open their mouth and say ah, and note for symmetric palate elevation. Shoulder shrug is innervated by the accessory nerve, which is cranial nerve 11. Have the patient raise their shoulders and move their head from side to side, all the while you're providing resistance as well. And note for any asymmetries or weakness. Finally, to round out the cranial nerve testing, you would also test for the patient's hypoglossal nerve functioning. Have the patient stick their tongue out and note for any tongue deviation, as well as any fasciculations noted in the tongue. Next, you'd want to be assessing for the patient's sensory exam. You should test for all the major sensory modalities, including light touch, sensation of pain and temperature, vibratory sense, as well as proprioception. Some major nerve fibers you should be aware of are A beta and dorsal columns. These are responsible for vibration and proprioception, while A delta, which is thinly myelinated, and C fibers, which are unmyelinated, are going to be involved with the pain and temperature sensation. As you can see in the video, you're just simply assessing light touch with just either your glove or your hands. Note each 4 extremities and note for any asymmetries to light touch. You want to grab a safety pin for assessing the patient's ability to sense pain on each side, and test both proximal and distal distributions on each side, and to determine if there's any asymmetries there as well. Finally, with the tuning fork, you're now assessing for vibratory sense. And once again, make sure you're testing for all 4 extremities and ask the patient not only what sensation they're feeling, and the answer should be vibration, but also if it feels the same on each side. Next up is the Romberg Exam, which is a great way to assess for the patient's proprioception. Now, the ability to maintain balance is actually done through three systems here. The visual input from our eyes is necessary, obviously, as well as spatial orientation from our vestibular system, and proprioception from our dorsal column. So what you would do is have the patient stand with their arms out and looking up at their feet together, and note for any kind of off balance or swaying or near falls. You should stand close to the patient, if not behind them, because they'll typically fall backwards in this case. Then you would want to have the patient close their eyes and note for any differences in balance. Having the patient close their eyes, you're actually removing one of those 3 inputs, the visual component of maintaining balance, and it may help localize your cause of ataxia to either the vestibular system or a posterior column disorder. Some definitions to note for your sensory exam. The term hypesthesia indicates that the patient feels a decreased sensation than what would be expected. Hyperasthesia is the opposite of that, and the patient feels an increased sensation compared to what would be expected. Allodynia is a pain or unpleasant sensation to an otherwise innocuous stimulus such as light touch. These patients are typically jumping off the bed if they've got allodynia. Hyperalgesia is the term used to indicate increased sensation of pain than what would be expected, such as to pinpricked. Next, we'll be assessing the patient's motor exam. Now, you'd always start this exam by just simply inspecting the patient. Should note for any abnormalities in posture or gross involuntary movements such as tremors or muscle twitching termed fasciculations. Now, tremors can actually be accentuated with certain postural movements such as holding their arms out against gravity. Tremors would indicate an underlying basal ganglia or cerebellar lesion. Muscle twitching or fasciculations indicate underlying lower motor neural damage, and this is typically a sign of chronic denervation. You should also note for any muscle atrophy or hypertrophy, which again, atrophy would go certainly in line with lower motor neuron lesions and muscle disuse. You should palpate major muscle groups to also elicit for any tenderness that would indicate an underlying inflammatory disorder such as myositis. What you're seeing here is the motor exam being carried out. So again, once again, you're going to start with inspection and note for any asymmetries on either side. In addition to that, you're going to have the patient raise their arms out. And these are some of the postural movements that I was mentioning that can maybe exacerbate any underlying tremor. You're next going to have the patient keep their arms out and and have them close their eyes. Again, this is testing for pronator drift at this point. Assessing for pronator drift is an important component of the motor exam. What you're going to do is you're going to have the patient extend their arms out to about shoulder level and have their hands supinated. Next, have them close their eyes and assess for any drift to the extremity, either upward or downward. Now, what's being tested here is pronator drift is a subtle sign of weakness in the corticospinal tract. It's actually very useful for neurologists. It may also indicate an ipsilateral cerebellar lesion, and closing the eyes accentuates the effect because the body must rely on proprioception. Continuing with the motor exam, you're next going to assess the patient's underlying muscle tone by having the patient relax while you actively contract various joints and determine for any underlying rigidity or flaccidity. Hypertonia such as spasticity can indicate an upper motor neuron lesion or a basal ganglia lesion, while a flaccid tone indicates a lower motor neuron or peripheral nerve problem. Strength testing is graded on a 0 to 5 scale, with 0 being no movement at all, 1 indicating some movement, perhaps a flicker, but otherwise limited muscle contraction. A 2 out of 5 indicates that the patient is able to move their extremity but not anti-gravity. 3 out of 5 is anti-gravity strength. 4 out of 5 is anti-gravity with some movement against resistance, but perhaps not at full strength. While a 5 out of 5 indicates that the patient is completely at their baseline and indicates full strength. You're going to be testing the strength of individual upper extremity muscles, starting with the deltoid muscle, which is innervated by the axillary nerve or C5 nerve root. The biceps muscle is innervated through the musculocutaneous nerve, nerve root C5, C6. The triceps muscle is innervated by the radial nerve C7. Wrist extension is also innervated by the radial nerve in addition to its branches with C6, C7 as the major nerve roots. Wrist flexion depends on which direction the hand is going. So with wrist flexion with hand abduction, it's innervated by the median nerve with C6, C7. With regards to wrist flexion with hand adduction, it's mediated by the ulnar nerve with C7, T1 as the major nerve roots. Finger flexion with your 4th and 5th digit are innervated by the ulnar nerve with C7, C8, while digits 2 and 3 are innervated by the median nerve, also through C7, C8 nerve roots. Next, we'll be assessing the patient's lower extremities, starting with hip flexion, which is innervated by the femoral nerve with nerve roots L2, L3, L4. Hip extension is done by the gluteal nerve with roots L4, L5. Hip abduction is innervated by the inferior and superior gluteal nerves with roots L4, L5, S1, while hip adduction is innervated mostly by the obturator nerve, in addition to some others, but mostly the obturator nerve with roots L2, L3, L4. Knee extensors, which are activating your quadriceps muscles, are innervated by the femoral nerve with nerve roots L3, L4, while knee flexion, which activates the hamstring muscles, are innervated by the sciatic nerve with nerve roots L5 through S1. Plantar flexion is innervated by the tibial nerve with roots S1, S2, and dorsiflexion is innervated by the deep peroneal nerve with nerve roots L4, L5. The next component of the neurological exam will be coordination exam. Now, some of this has already been done earlier, and you can kind of get a sense of the patient's coordination, but you would want to continue and follow through with this as well. First, you would assess the patient's ability to follow with finger-nose-finger testing. And the inability to perform this test accurately is called dysmetria. And this localizes to cerebellar lesions secondary to maybe stroke or MS or tumors or any other kind of cerebellar lesion. Rapid alternating movements is another test for coordination. And this would also localize to some sort of cerebellar damage, usually ipsilateral. Inability to do so is labeled dysdiadochokinesia. Finally, gait testing is also very important as you want to assess for the patient's ability to kind of incorporate multiple sensory and motor systems. And gait testing is a great way to kind of assess for the patient's vision, proprioception, vestibular sense, and motor extremity strength. What you would do is you'd have the patient carry out the following 4 tests. First with casual gait testing. Next with heel walking, which is really a test of dorsiflexion. Walking on the patient's tiptoes, which is a test of plantar flexion. And note for tandem gait, which is often used by police officers when they're pulling someone over suspected of drinking and driving. Note for any asymmetries, and also note posture and characterize the gait as best as you can. For example, a shuffling gait can indicate underlying Parkinson's disease, while a gait where the patient barely moves their feet above the ground, or off the ground rather, indicates a magnetic gait, which can be seen in patients with normal pressure hydrocephalus. Finally, would be assessing the patient's reflexes. Now, it's also graded on a 0 to 5 scale. 0 meaning areflexia, 1 plus indicating hyporeflexia, 2 is a normal reflex, while 3 plus is hyperreflexia, 4 plus is non-sustained clonus, where you'll have a few beats of repetitive and rhythmic movements or contractions, but they do stop after a few beats. 5 plus indicates sustained clonus, and this is pretty pathologic. Now, the clinical significance of this, well, absent or hyperreflexia can indicate lower motor neuron lesion, which would localize to the anterior horn in the spinal cord or peripheral nerves coming out of the spinal cord. However, brisk reflexes or hyperreflexia on the other side will indicate an upper motor neuron lesion, which localizes to the brain or spinal cord. The biceps reflex is through nerve root C5, C6. The brachioradialis is through nerve root C6. The triceps reflex is nerve root C7. The patellar reflex is nerve root L4, and the Achilles reflex is mediated by nerve root S1. An important test that would be of use to you would to conduct the Babinski's test. What you're doing is you're checking for the plantar reflex or the plantar response. Scrape an object across the sole of the foot, starting from the heel, and work your way up on the outer edge while moving in. And a positive test is an upgoing big toe with fanning outward of the other toes. Now, the Babinski sign is actually normal in infants, but is pathologic in adults.